Well, welcome everybody to this special live stream. My name is Dr. Fuz Rana. I'm a biochemist and a Christian apologist. I'm also the Vice President of Research and Apologetics at Reasons to Believe, which is the organization that is sponsoring this live stream. If you want to know more about Reasons to Believe, please go to our website, www.reasons.org. The purpose of this live stream is to answer the questions that we are commonly hearing from our constituents at Reasons to Believe, questions about COVID-19, about the COVID-19 vaccines, and about COVID-19 treatments. And unfortunately, we live at a time where there's a lot of conflicting information about all three of these topics. And our constituents tell us they really are not sure where they can go to get trustworthy information. And so in our attempt to serve our constituents, what we've decided to do is to put together a panel of medical experts to help answer these questions. And so I'm joined today by Dr. Mark Messinese and Dr. Francisco Delgado, who are going to help us answer these really important questions about COVID-19, the vaccines, and the COVID-19 treatments that are available. When it comes to identifying two people that I consider personally to be trustworthy to answer these questions, I can't think of, again, two better individuals. I've known both Paco and Mark for a number of years. I consider them to be friends first and foremost, but also I deeply respect and admire them because of their academic and professional accomplishments as physicians. These are also two men that are part of our scholar community at Reasons to Believe, and they also serve in leadership capacity at Reasons to Believe. Dr. Mark Messinese was a past RTB board chairman, and we just elected Dr. Delgado to be part of the RTB Board of Directors. Also, these two gentlemen have the distinction of being on the front lines, actively treating patients that are suffering from COVID-19. So again, I can't think of two individuals that would really be more trustworthy as a source of information than these two gentlemen, who also, by the way, are Christians who are men of high Christian character. And so again, I consider them to be trustworthy individuals. Before we get started with the questions that we want to tackle today, I'd like for each of you to take a moment and just introduce yourselves to us, please. Maybe Mark, we'll start with you, and then Paco, after Mark introduces himself, please, why don't you go ahead and introduce yourself?
Thanks, Buzz. My name's Mark Messinese. I'm coming to you from Jacksonville, Florida, on the East Coast. And first of all, I'm honored to be a part of this discussion and really appreciate the opportunity. Thank you, Fuzz and RTB. I am a critical care internist who was in private practice for almost 30 years. And 8 years ago, I transitioned to geriatrics only, and I run a continuing care retirement community here in North Florida and take care of elderly folks that live independently as well as in the nursing home. So right now I'm looking after the infirmed and the very old, but prior to that I was in family practice and took care of essentially adults. I live here in Florida. I'm married and have a number of grown children and have been a part of RTB almost 20 years now. So I'm very pleased to be a part of this discussion.
Paco.
Sure. So I live in Indianapolis. I have been an infectious diseases physician now for over 20 years. My wife is Canadian. We have a very international family. My daughters were born all over the United States. I have a group of infectious diseases doctors here in one of the major hospitals in Indianapolis. And amongst all of us, we probably have seen over 3,000 patients with COVID. Every day, we probably attend to about 20 to 25 patients in our hospital system. We've been dealing with this since the beginning. We've been involved in research projects. We were very involved with the recruiting of patients for multiple different trials for drugs and for treatments that we thought would be useful for coronavirus. That's essentially it. All of us have been touched one way or another with this pandemic, and probably seeing so many people die in the hospital is very heart-wrenching.
Yeah. Now, both of you are, again, not only, highly respected physicians, but you also, again, are Christians and deeply committed to your faith. I know, again, from firsthand experience in our friendships. What motivates you as a physician? How does your faith, I should say, really motivate you as a physician?
You want to start, Mark?
Yes. I now take care of people really in the end stages of their lives. That's not what I did always in the past, but now I'm really involved at that stage of people's lives. And so I have the honor of being involved in people's lives really right there at the end. And for me, I'm motivated really by wanting to eschew pain and suffering. I want the quality of their lives to be as good as possible. I want to be an agent of comfort, and I think also hope. And so not only does that involve, medical practice, but it also involves my faith. And I think my worldview and outlook just on the world itself. And there goes my, just lost my camera. I'm sorry, but we'll get it back.
Paco, why don't
Sure.
you take on that question?
So I resonate a lot with Mark's answer, because one of the things that we as physicians look for is try to ease suffering. There is already quite a bit of suffering in this world. And if we can do a little bit to alleviate people's ailments, it really is the goal of what we do as physicians. So what motivates us? First of all, and as Mark says, hope is what has to be at the center of our practice, trying to bring a little bit of joy, showing the love of Christ in everything we do. I think those three things are the main ingredients in our practices.
And then let me ask both of you this question. If a patient comes to you and they are seeking advice on whether or not they should be vaccinated against the COVID-19, or if you have a patient that is suffering from COVID-19, what motivates you as you engage patients who are concerned about this disease or who are suffering from this disease?
Yes, let me take that then, Mark. The disease is very, it has multiple stages. And really the questions can come from people who are, who have not had COVID and are wondering what is the risk. It could be people that are in the early stages or are in the late stages. So let me try to put a framework of what COVID is. COVID is a virus that is transmitted through the air. Initially, when you get exposed, or when people get exposed to it, there is going to be a period of what we call asymptomatic carriage. And then during that period, you could still be producing virus that can go outside of your body and infect other people. Once your immune system starts kicking in and starts recognizing this new pathogen as something to really be concerned about, then it'll start mounting an inflammatory response. Initially, it shows like fever, headache. That's when you start losing your sense of taste, of smell, fatigue. Those are really the early stages of the disease. Now, here's when risk factors start taking a very important role. if you don't have risk factors, if we don't have risk factors, then you're going to go through the disease and you're probably going to be okay. But if you have risk factors, and the risk factors include age, obesity, diabetes, high blood pressure, immune suppression, like you're taking some specific immune suppressant drugs, or if you've received a transplant, an organ transplant, then your risk for developing what we call severe COVID is going to be high. And severe COVID, essentially, that's when the lungs start failing. The lungs fail mostly because of an inflammatory reaction. That means the immune system is very active and trying to get rid of the damage that the virus has left in not just in the lungs, but in all of the body. Whenever people end up in the hospital with the low oxygen levels, which is, what brings people, you look in your oximeter, and yeah, oxygen is low, you end up in the hospital. I tell my patients, now that you're here, chances are that you're going to be staying in the hospital about 10 days at least. Sometimes that hospitalization can last for 2-3 weeks. It's not unusual to see that. Some people, even though we do everything we can for them, they go and they worsen. That's when we need to put them in the respirator, artificial respirator, so that we can try to push as much oxygen as we can. And yeah, a pretty good proportion of people that end up on the ventilator will end up dying. And the disease, up to the time of death, can sometimes take up to 4 or 5 weeks. So it is a very long disease. So the questions that you are talking about, Fuz, they vary depending on where people are in that timeline.
Mm-hmm. Let me ask you this, Mark. Does COVID-19 concern you as a physician?
It really does. I remember a few years ago, I had a patient in his 40s die from influenza, and we were shocked. I had never seen a young person die from influenza. We'd given flu shots for years. And yes, I had hospitalized elderly people with influenza and pneumonia, and rarely someone would die. But I have never seen anything like this in my entire life. And so as I watch the number of people in my community, friends younger than me, my age, and then of course the elderly who have died, it's staggering to me. And I had a brother that was in the ICU for 3 weeks and almost expired. And as I spent that time with him in the ICU, as a doctor who spent his life in the ICU, I had never seen such illness. I felt like I was in a war as I would walk through the hospital. So yes, it's like a bad dream to me, I have to say. And like Paco, I've been all over the world, Central America, Africa, seeing people without health care. I have never seen anything like this. So I'm very concerned because I've seen robust, strong people, not just the infirmed, become deathly ill and die. And I've never seen that before in my practice, ever.
Let me ask you this question about kind of the long-term effects of COVID. Obviously, there are risks of people, dying, from COVID-19, but what are we beginning to understand or learn about long-term effects? Because, I'm not obviously a biomedical expert. I'm a biochemist by training, but as I read about this, I'm seeing statistics like roughly a third of the patients suffer from some types of neurological issues, that there may be long-term consequences like the onset of type 2 diabetes and other types of cardiovascular diseases that people become more vulnerable to as a result of COVID-19. So what is your opinion, both Mark and Paco, on the long-term effects of COVID-19? Is that also an area of concern?
Yes, they are real, and they can last for maybe weeks, months, sometimes a lifetime. COVID is not just a disease of the lungs. It causes some abnormalities in the blood clotting cascade. So we have had patients who have developed strokes, and I mean, you get a stroke, that is a life-changing event. But I've had, as Mark says, young people who even months after they continue having difficulty breathing. Some people that after also many weeks and months continue having what they discuss, what they say is like a mental fog, and it is very difficult for them to continue doing their activities. Yeah, what is your experience, Mark?
Well, I certainly think that time's going to tell. We're going to be able to look back in a few years and we'll have a much clearer picture of what they call long haul or long COVID. But I have seen people months after the disease still disabled, especially the brain fog and the overwhelming fatigue. And then I had another colleague, who was telling me about young people walking in his office with strokes. And lo and behold, they had COVID, and the tendency to form blood clots had stayed with these people for a while, and they had presented with the effects of blood clots, which is devastating. These are irreversible sorts of things. So I'm very concerned about it. I really am. And I don't think we really know now at this point in time what it's going to look like. But my concern is that there really could be some long-term effects of getting the virus in some people that we will look back and wish we hadn't gotten the virus.
Here's a question that's come in from the chat from somebody, Dan B. He asked, any advice for the treatment of long COVID? I had a very mild case, and then on day 11, I developed brain fog and extreme fatigue. So is there anything that's being developed in terms of treating patients with long COVID?
Yeah, at least in my area here, we are starting to open clinics for long COVID patients who've had COVID, and after 12 weeks, they continue having symptoms. They are referred to this clinic. And as Mark says, we're going to be learning a lot more, but right now they're trying to bring people back to their usual baseline where they were before this COVID. I don't know what is going to entail. This is an area that we're going to be learning a lot in the next several weeks to months.
Here's another question. There's a lot of people that really mistrust the government agencies. For example, the Center for Disease Control, the CDC, and they feel as if the numbers and the severity of COVID-19 are being exaggerated. Right now the reports are since the onset of the pandemic in the United States, about 800,000 people have died from COVID-19. 600,000, I believe, was the number approximately before the vaccine was available. So do you think that the government agencies are exaggerating the numbers of COVID-19 patients?
I don't think so. I mean, it is, it's very interesting to see, and I see this very often, two perspectives: the perspective of people outside of the hospital system, where maybe they know one, or maybe they don't know nobody who's been sick with COVID, and us physicians like Mark and me and our group, who's been dealing with thousands of people that that end up in the intensive care unit and even dying. So the numbers are there. The perception is different because of probably of the populations that that we're talking about. I think, Mark, you would say that within your population, probably there's a lot more awareness because you've got a population of much older people. Would you agree with that?
I would, and I would say to the questioner, I read the same data that he or she does. Okay, I don't have any special knowledge. I read all the sites, I read my medical journals, but I can tell you that never have I ever seen anything like this. All you have to do is saunter through the halls of a hospital, which I have done for over 30 years, and it is an overwhelming epidemic. and the numbers of sick people. All you have to do is walk in the emergency room, and they're in the halls, up and down the halls in stretchers. We don't have enough rooms. At least we didn't during Delta. I hope that's not the case with Omicron. But during the Delta outbreak, our hospitals here were absolutely overwhelmed, and we were building extra wards. So if that's an indication of anything, the numbers certainly seem to be real to me. This is a crisis the likes of which we've never seen in our lifetime.
Okay, so let's shift gears a little bit now and talk about the vaccines. And really, I think the question on everybody's minds are the vaccines safe and effective? Because, the vaccines represent a very powerful tool, I think, in the fight against COVID-19. So what is your perspective on the vaccines? Are they safe and effective?
Yes, they are very effective. Now we have to define what effectiveness means. People have, what I would consider effectiveness is that you get a vaccine, you do not end up in the hospital. You may have a little bit of COVID, something that you can deal at home like a cold. To me, that really is not a problem. But if we can prevent people from ending up in the hospital and dying, to me, that is an effective vaccine. And just to show, I think, Nick or Brandon, you have the graph of the circles. Can you pull it up if you don't mind? I can tell if it's up or not. Okay, great. So this is a graph that I just took today from the Indiana State Department of Health. And if you can see, that's the big circle. Is it there? I don't see it here. Okay, great. Perfect. I'll tell you what it is. So essentially, the big circle that you see there is the number of fully vaccinated people. And as of today, there were 3.5 million people in Indiana. Breakthrough cases, those are cases in which you were vaccinated, but people just got a cold, and okay, no big deal. That's 94,000 people. Now, look at the number of hospitalizations. It's only 1,800 out of all out of the vaccinated population. The breakthrough deaths, only about 980 people. The vaccines have definitely brought down significantly hospitalizations and death, to the point that right now in our hospital, we may have about 95% of people that are unvaccinated, and probably about 5% or less that have received full vaccination. So vaccines are effective. Yes, they are effective. Safety. Regarding the safety, there has been a lot published on the vaccines. Probably the ones that have given us the best data have been the groups in Israel. They have shown that what are the main side effects of these vaccines. People have heard a lot about issues like myocarditis, etc. We need to remember one thing, that coronavirus in itself, if you get coronavirus, you can get myocarditis just from the virus itself. So the risk, for example, of myocarditis with a vaccine is less than getting myocarditis from COVID. The rest, really, the side effects that the Israelis have reported are very, very minimal, which makes me think, yeah, you know what, this is actually a product that when you put it on risk-benefit ratio, I would say, yes, it can prevent hospitalizations and death in a safe way. That would be the general claim that I would say.
Mark, what's your opinion? The vaccines safe and effective?
Well, simply, yes, they are. And, I'm asked this question every day, and have been for months and months. And, I just have to say that as a patient myself, okay, I really think it depends on your expectations. What are you expecting from a vaccine? And I don't think we really thought about it much, because in our lifetime, we've enjoyed not having epidemics and huge outbreaks of disease like maybe my parents did, where my parents lived during the polio era, which terrified them. I've never experienced that. I've been major disease free because of the vaccinations that I've received in my lifetime. But if you begin to look at those numbers, you realize that they're not perfect. They don't keep everybody from getting the disease. Some people get really sick from vaccines, but on the whole, major numbers of people are saved from horrible diseases like the rubella vaccine. So, I was just thinking about the influenza vaccine, Fuzz. That's been the big push in my practice for years. And what are we looking at, Paco? 40 to 60% effectiveness with the influenza vaccine?
Yeah, that is low. I will absolutely.
It's quite low. But the thing is that even if our patients get influenza that have had the vaccine, I know this for certain because I've hospitalized many of them. They're never as sick as the person who didn't get the vaccine. And for me, that was a success. And I've had the experience now of taking care of unvaccinated patients like we all did, especially before the vaccine, and watched many of these patients die or have a very terrible illness and end up with disability. And then I've watched them get the vaccine and then get COVID, okay? I was really surprised at how mild the disease was compared to the unvaccinated. And these folks lived, and they were able to get on with their lives afterwards. And I thought, that's a success, but I think it all has to do with our expectations and what we expect from vaccines. And I think if we look at them in view of history and what vaccines have done for us historically, I come to the conclusion that the vaccines are safe and they certainly are effective. They do what we hope vaccines would do, and that is they attenuate the disease. In some cases, they keep us from getting infected. In other cases, they keep the infection from running rampant and really causing great harm.
Okay, so let me ask this then. Are the side effects, in your opinion, are the side effects that are being reported for the vaccines being reported faithfully? Are they being reported in a reliable way? And there's this site called VAERS, right? VAERS, that seems to show a high number of severe reactions and deaths as a consequence of taking the COVID-19 vaccines. So, what are we to make about those kind of reports?
So, in our experience in the hospital, since the beginning of a pandemic, we have not seen anybody with a serious side effect from the vaccine, which tells me that if they exist, they are rare. And it's the reporting. Of course, I can only tell you what we get from the from the data that is reported, but we can also cross-check it with other areas in the world, and that's why I brought up the data from Israel, because their system essentially is mirroring what we are seeing here regarding side effects of the vaccine. So, I mean, that's really what I can tell you about all this.
So what are we to make, Paco, of the VAERS claim, or the VAERS reporting? I don't know. That's when you could get into, okay, is there a conspiracy theory or not? I think as Christians, and this is what I tell, people, if we are Christians, the whole idea is that we need to seek the truth. And truth sometimes is very difficult to find. Looking around and looking at what we see, again, we've been dealing with this pandemic for the last 2 years.
the reports that we see in social media, looking at what we see as actual physicians caring for patients with COVID, seem exaggerated. That's the experience that we have. We cross-check it. Our group of infectious diseases physicians, we are very, very careful on what we offer our patients. We try to give them the best therapy, the best care that we can. If any new product is brought up purporting to treat COVID, we do a full evaluation of it. And we ask the question, would we use this ourselves if we got to that point? If we got COVID, if we got severe COVID, whatever, would we use it ourselves? And that is a big question that we all have. If one of us says, no, I won't, then we take a pause and re-examine the data, or we wait for more data until it comes out, and we can all agree that a product is a safe product to use in our patients. And so far with the vaccines, we're all in agreement. Yeah, I mean, there's a degree of safety that and an effectiveness that is, we cannot deny.
Okay, now here's a couple of other quick questions that I think a couple of people in the chat are asking that are important questions. One comes from Jacob, who says, since we are now aware that vaccinated people can still transmit COVID and young people / children with no comorbidities are at lower risk, should children be receiving the vaccine? And then Cecilia asks a similar question, would you advise young people and children without risk factors to take the vaccine despite not knowing future risks of the vaccine? So there's a number of questions in that. So
they're great questions.
Yeah, maybe Paco, if you start, and Mark, I'd invite you to jump in as well.
Let me bring up a couple of graphs. Nick, let's do the let me see, let me pull my slides here. The slide number 3, the one that has the COVID infection fatality rates. You got it there? Okay. So yeah, things, every time we make a decision, we always have to put risk benefit analysis. We need to see what is the risk of something, what is the benefit of something. If you look at the age groups in this table, you will see that the risk of death actually increases significantly after you are in the 65 age range. The older you are, like the 80 plus, your risk goes sky high. Another way to put this, you want to move to the next slide, please, Nick. If you compared the risk of a person getting COVID according to age, let's use, then they're using, this is from the CDC, using a reference group, the 5 to 17 years old. If that was the reference group, look at what is your risk for hospitalization and death according to age. If you are in the 85 plus years old, your risk is 8,700 times higher than someone that is 5 to 17 years old. Now, if you put then the risk-benefit ratio in adults, oh, by the way, and this is adults without considering risk factors, because you can have a young person, let's say someone who's 40 years old, who is overweight. And by the way, we've seen children, 17 years old that are very overweight, and they can get extremely sick and sometimes even die. So this is without considering risk factors. If you put risk factors, these numbers would go higher. And the number of risk factors that you accumulate, the number will go, extremely high. Anyways, so all that to say that people that are older and that have risk factors are the ones that would gain the most from getting the vaccine. When we're talking about children, yeah, the risk to the child of severe COVID, hospitalization, or death is low unless there are risk factors. And again, risk factors, obesity, immune suppression, other things. So that is one thing that needs to be taken into consideration when making a decision about vaccination. The other consideration about vaccination in children would be if a child is close to someone who has high risk of dying with COVID. Let me put it, for example, in an older adult, let's say that we have an adult that is a heart transplant. We know that even if we give, 2 doses of vaccine to a heart transplant recipient, those vaccines have a high risk of not taking, meaning that they will not protect them. So if you have, for example, a child that lives in the household of someone who is at a very high risk of dying from COVID, then I would make a case that child would actually, be providing some sort of protection to this vulnerable person. I think that you have to take into consideration those scenarios when you're making a decision whether you're going to vaccinate your child or not.
Okay, so the best thing then probably would be for that person who, maybe has a child or who doesn't have any obvious comorbidities to really be in consultation with their physician about that, as opposed to maybe making that decision independent of any kind of input from their physician. Is that what I hear you saying, Paco?
Absolutely. Fuz, the medical history, the specific, I give a talk on COVID very frequently, and the very first slide that I have is, one size does not fit all. Whatever we put here is a very general idea. Every person's situation is very, very particular. And those situations, those medical issues, those social issues have to be discussed definitely with their primary care physician to make a more informed decision about whether the vaccine would be useful or not. Yes.
Mark, let me ask you this question. What about a woman who is pregnant, or a woman who's breastfeeding? Would you recommend they get vaccinated against COVID-19? Because I understand that pregnancy is actually considered, quote unquote, a comorbidity, right?
Right. Well, from everything, now here again, I'm not an obstetrician, but from everything I've read and the data that I've seen, yes, they should. And fortunately, they pass on passive immunity to their newborn if they're breastfeeding and they've been vaccinated. And I know that in my family, one of my daughters-in-law was vaccinated whilst she was carrying her baby. And, this is not obviously a trial, but everything went very well. And I was very happy that she did get vaccinated. And I think the data bears that out. Fuz, I did want to ask Paco a question. I am questioned often, especially when it comes to vaccine in children, about the concern of myocarditis or pericarditis. And I know the Israelis have done some studies on this, and where they looked at the risk of myocarditis in the young if they got COVID versus the incidence of myocarditis from getting the vaccine alone. And am I correct to assert that the incidence of myocarditis is higher in those that get the virus than those that get the vaccine? And yes, there is an incidence of myocarditis with the vaccine, but if you get the virus, there's a higher incidence, quite a bit higher. Am I correct to assume that?
That is correct, Mark. Yes. And usually the cases of myocarditis are mild. The Israelis have really reported a very, like a handful of people who have died from myocarditis. I think it's only like 1 or 2, less than 5. Anyway, so it's very, very rare. I wanted to go back to your question also, Faz, about the pregnancy. We have seen in the hospital a disproportionate amount of pregnant women with extremely severe COVID, to the point that we have had some die. Yeah, and the reason is pregnancy changes the immune system. So the response of the immune system to COVID is going to be much more aggressive during pregnancy. And it is very disheartening to see young, no risk factors, pregnant women coming to the hospital with very severe COVID, yes.
Okay, why don't we just shift gears, because this is a fascinating conversation, and we want to be sensitive to the time. But let's move on to something that is extremely controversial, and that has to do with effective treatments for COVID-19. And the first thing is, apart from the vaccines, which you could argue are highly effective prophylactics, are there anything that we could do to prevent ourselves from getting COVID apart from the vaccines? There's people that are, arguing that, hey, if you take a regimen of vitamin D, zinc, and vitamin C, that should be sufficient to ward off COVID-19. So are there effective prophylactics that we can take apart from the vaccines to prevent us from contracting COVID-19? And let's start there.
All right. There's many things that we need to consider. Your immune system requires very good nutrition. And unfortunately, in the United States, we have pretty high rates of malnutrition. Last figures that I found out were that about 40% of the population of the United States is deficient in vitamin D. So no matter what you get infectious wise, to have a good immune system, you need to have good nutrition. So if you're deficient in vitamin D, yes, supplementation of vitamin D is going to help your immune system to combat any kind of infection, not just COVID. We do not have data that zinc or vitamin C help at all. What I tell my patients, if anybody calls me that they've got COVID, right now, the best thing that we have found that decreases hospitalizations and death is something called monoclonal antibodies against COVID. It is very important that people get these within ideally the first 7 days from the onset of illness, because they don't work after like a 10-day mark. And actually, there were some data that possibly could be a little bit more harmful. So the message that I would say, if you get COVID, as soon as you can, ask your physician if you would be a candidate for getting these monoclonal antibodies, because they decrease hospitalizations above 70%. That would be what I would say.
I would agree with that, Fuz. I have seen the effects of the monoclonal antibodies in patients that I was very worried about, who were severely immunosuppressed. And I really think we pulled them out of the fire, so to speak, once they got the monoclonal antibodies. And I know there are a good number of studies that show that. And in my state, it's pretty easy to get. Fortunately, we have infusion centers all over the state. And so we've taken advantage of that.
Now, isn't Merck developed some kind of, I think it's a nucleic acid or a nucleotide analog that's presumably is showing some promise in terms of reducing the risk of hospitalization? And the hope is that could even be available as a prescription that people can just go to the pharmacy and get. I'm not sure, I don't remember the name of the drug off the top of my head, but
yeah, the Merck product actually is not very good. In the latest data that we reviewed, it's only effective in about 30% of the time, and it seemed to have some significant side effects. However, there's a Pfizer product that is coming up that seems to be much better than the Merck product. But yes, ideally, that would be a pill that we can have to prevent severe COVID.
Yeah, but right now there's really nothing other than monoclonal antibodies that, okay. Now, what about ivermectin? Of course, this is, highly contentious, highly controversial. What is your opinion on ivermectin?
So I tell you, doing medical research is very difficult. It takes a lot of people. It takes a lot of time. It takes a lot of money. And to make a study that is that gives us a good answer sometimes can take a long time. I know there's been a lot of studies that have come up with ivermectin, and most of the problems with the ivermectin studies are something we call bias. Nick, I think you have a graph about that. I mean, a slide on that. There is an analysis of all of the studies that have come up in ivermectin and the risk of bias. There was actually one fraudulent study that was essentially removed. And if you take that fraudulent study, which is the bottom on the right, the likelihood for ivermectin working decreases. Now, when we examined those studies, many of them had a very high risk of bias. And what I'm saying that is people were not being randomized and stratified adequately. So it is very difficult to make an adequate comparison whether your treatment is working or not. Once you take away the high risk of bias studies, you are left with studies that have some concerns or low risk, and those are not giving us a positive answer. They're not telling us that ivermectin works. Right now, there's an ongoing study in the UK that is very well designed, trying to answer for good this question of whether ivermectin works or not.
Mark, do you have any thoughts on ivermectin?
Well, I would just echo what Paco said, and that is, we know that it takes a lot of patience and some very, intelligently designed studies to be able to factor out bias. And, we just haven't had time to do that yet. And so, at this point in time, people ask me all the time, and they bring up the country of India as an example. And, I'm not a researcher like Paco. I'm not in that business. I'm just at the grassroots or at the ground level treating patients. And I tell them, look, I can't use something that I am not convinced will help you. I just couldn't do it in clear conscience. Now, if studies come out and show that it really works, and we apply the same rigor that we apply to every other treatment that we have in America, which, thank goodness, keeps us from giving people drugs that don't work, then I would change my mind. I'm very open to these ideas. And I have to admit, that I have felt a lot of pressure from patients. Doctors are not immune from that. They want me to give them this and give them that, and they've heard this and they've read this and that. And can I admit that I'm tempted sometimes, but I don't, because I don't want to give them a false hope or give them a treatment that could eventually end up hurting them. And so I hope that our listeners understand that most of us, we want to do what's right, and we just don't have clear-cut evidence yet.
Okay, now let's cycle back to the vaccines for a quick second. If somebody does wind up contracting COVID-19, do you recommend that they get vaccines? This is a question that Ryan asks in the chat.
All right. So let me go back and do you have two different things that we need to think about here. You have a design of a vaccine that is against only one portion of the virus. And let me see Nick, let's see if we can pull these two up. The one that says natural immunity first. Let me start there. Whenever, we're going to use the coronavirus here. When the coronavirus enters your body, it'll go through something called antigen presenting cells, and it will trigger the activation of the immune system. The virus is made out of many different proteins, and each one of those proteins has the potential to elicit an immune reaction. So when you have a natural immunity, that means that your body will make different kinds of antibodies and will have specific cells that will recognize many or many of the parts of the virus. When you have vaccine, and especially these the vaccines that we have right now, which target the spike protein, vaccine immunity will activate and create antibodies against only or mainly the spike protein, both humoral and T-cell related immunity. So if you had COVID, and this is fascinating, because if you have COVID, you will have both antibodies and cell immunity for some time. And for how long, we don't know yet, to tell you the truth. It seems to be at least about 6 to 8 months in people who do not have risk factors. We go back to the risk factors idea. However, your immunity is going to be specific to the strain that got you infected. Now, let me go back, Nick, between the two graphs, there's this, the table that has the natural immunity, depends on strain. If you get infected, let's say with the original Wuhan virus, that will give you immunity against the B117, which was, I think, the beta strain. But this strain, the B1351, the immunity didn't look that good. And for example, in Brazil, when the Gamma strain came out, people in Brazil, even though they had had infection with the original Wuhan virus, they went on and got reinfected again with this strain, with the Gamma strain. So natural immunity, again, is pretty much very specific against a virus. Why do we have observed, and this is very interesting, that if you get natural immunity and you get at least one mRNA vaccine, your immune system actually will recognize all of these different strains and will have immunity, detectable antibodies against, so far, all the strains that we know about. So even if you're vaccinated, I mean, even if you got COVID, if you get at least one shot of the mRNA vaccine, your immunity goes much, much higher against many of the different strains. I don't know if that was clear enough.
Yeah, that was, and you know, because now, you know, obviously we're concerned about the Omicron variant. That the latest that I've seen is that it's on pace to actually now become the dominant strain of you know, SARS-2 coronavirus, you know, in the United States and probably many other places around the world. And so, you know, you know, what I mean, it seems like, you know, this is almost like a no-win situation, right? That as these new variants emerge, you know, just how effective ultimately are vaccinations going to be? How effective ultimately is natural immunity going to be, right?
Yes, and I think it's going to be the play on how aggressive is the virus, and also what kind of population we're dealing with. Because so far, at least so far, we know Omicron doesn't seem to be as severe as we had Delta. That's a question on whether, you know, the vaccines are going to be covering these viruses. We don't know. We actually have a couple of graphs that just came out today. And Nick, I think it was or is it? We don't have the data for that one yet. Anyways, yeah, we still don't have the data for how Omicron is going to fare with the vaccines that we have. If Omicron turns out to be not a lethal variant, then, you know, hopefully that won't be much of a problem. But there is a concern, and, you know, there's something that we will know. Will there be a variant that will be arising that will be resistant to the vaccines that we have? Yeah, it's possible.
Okay, let's quickly take on some of the other types of questions that people are asking about the vaccines. So, for example, Mark, are there any concerns on your part that the vaccines might modify our DNA?
No, there aren't any concerns. And everything that I understand about how the vaccine works tells me that it's not going to modify our DNA. And that pretty quickly after the mRNA, which is in the vaccine, is translated, it's degraded by the cell. But I would remind our listeners that we get all sorts of viruses. My cold sore that has been with me for 45 years has modified my DNA, and the DNA of that virus, herpes simplex virus, lives within the cells of my body, and every once in a while, when I'm under stress, that DNA, which is integrated into my own genome, is copied and causes a vesicular eruption on my lip, to the horror of my wife. So yes, some viruses do that. In fact, all of us have some viruses that have integrated into our own genomes and are part of who we are. But as far as I understand, no, this vaccine doesn't do that.
What about causing, Mark, the vaccine causing infertility?
You know, I don't know that I can really speak to that. I've heard that claim, and I don't know that we have any robust data at this point in time. It's kind of early, but maybe Paco can speak to that.
I can't, because we don't have any data about any signs of infertility at this point.
Yeah, you know, one of the arguments towards that end that I've seen was that there's similarity between the spike protein that is being produced through the mRNA and I think syncytin, which is a protein that is involved in the early stages of placental formation. But you know, again, if that was the case, then you would expect that the infection with the SARS-2 coronavirus would also cause infertility as well, because you also are being exposed to the spike protein. So the concern would be that the antibodies that you raise would then attack the placenta during the process of formation. So I'm not even sure if that's a possibility. Again, I'm not a medical expert, but it just seems to me that if that's the argument, then there really isn't mechanistically any way that the vaccine ought to be causing infertility, right? And I also understand that during the original phase 3 clinical studies, both conducted by Moderna and Pfizer, the patients that were involved in that study were instructed not to become pregnant, and there were people in the study that became pregnant. And so there seems anecdotally to be data that argues against that. Mm-hmm. But both of you are still open-minded on that question.
Yeah, because we don't have any data at this point, at least clinically. I mean, and sometimes, as you know, things that happen in the bench do not necessarily correlate to what happens clinically. So yeah, I have no answer to that. Okay,
great, fair enough. And then let's see, what about this? Are there microchips in the vaccines?
Dr. James Torr in his website, in his YouTube channel, has a very clear video, about a 2-minute video that shows you no. I mean, he's the expert in nano machines and all these things, and essentially no, there's no chips in that.
Yeah. Well, you know, this is something that when people ask me these kind of questions, I try to understand a little bit about maybe what is the basis for that claim. And apparently, you know, one proposal that Bill Gates has made over the years is to actually incorporate quantum dots into vaccines, which would then provide a very quick record by simply scanning that individual skin at the site of the vaccine as a record of what types of vaccines that individual has had. So, you know, I'm sure that that's probably influenced the claim, but it would be easy enough to determine that. You could just pull a vaccine off the shelf and do a chemical analysis and determine whether or not there were microchips in there. There's going to be a clear chemical signature if that's the case.
And that's why I go to my nanomachine expert. And that's why she says no. It's like, okay, I trust him.
Yeah. Mark, any thoughts?
Yeah, Fuzz, I agree with Paco. I have heard that, and if there are nano machines in it, I mean, I'm filled with them because I got 3 vaccines, 3 injections. But with all seriousness, I understand that would frighten people, and if you're not familiar with how these things work, one could make a case that might sound plausible, and that would frighten me also. So I don't discount that, but I believe that all the evidence is that at this point in time, no, that's not the case. They are just my cells with mRNA in the middle of them.
Okay, why don't we go ahead and take questions from the chat. We've been taking a few questions as we've gone along. So let me just quickly scan some of these questions to see if there's some. Terry asks, how long do antibodies last from the vaccine? And then maybe we could combine that question with a question from Robert, who says, is the measurement of antibodies the proper method of determining virus resistance? So Mark and Paco, I'll just, whoever wants to take that.
Sure. We are going to be talking about a hypothetical patient who has a normal immune system, because if you have someone who does not have a normal immune system, then all bets are off. So far, we know that if you get vaccinated, well, actually, let me go back. If you get infection or if you get vaccinated, your immune system will produce 2 things. One is antibodies, which is part of the humoral immune system. And your body will also produce special cells, which is a cell-related immunity. Now, antibodies may wane down over a period of about 6 to 8 months. It does not mean that you are not necessarily immune, because we do not have a very good way of measuring the T cell or the cell response to either the virus or the vaccine. So some people may be immune without necessarily having antibodies. And also another thing that you need to consider is you may have a lot of antibodies, but those may not be the right antibody for the virus that is going to come next and infect you. So there's a lot of little caveats with the question. Yeah. I hope that we address both answers there.
So, under ideal circumstances, do high antibody levels translate to a type of sterilizing immunity that would prevent you from getting the disease versus relying on, T cells and B cells?
If you have neutralizing antibodies against that specific strain, I would say, yeah, if you have them, it would be an adequate marker. And the question is this neutralizing antibody, is this the same strain that you're trying to protect? Those are the 2 questions that would have to be, addressed.
Mark, any thoughts?
Well, yeah, natural immunity can decay, within 3 months to anything that we become exposed to. However, it's interesting. I know the vaccine studies have shown that the immunity lasts longer from the vaccines, up to 6 months. But the good news is that God has endowed us with memory cells. And, we have an immune system that, even though our antibodies may not be at a very high level at a certain point in time, if we are exposed to whatever antigen we're talking about, if we've got good memory cells, we're going to make immunity very quickly. And that's what I would be concerned with. And like Paco said, we don't really have really good testing for that on a large scale basis. But I'm counting on my T cells and my memory cells to be with me for the rest of my life and to be able to recognize this virus. But I agree, if I could have high antibody levels, I would take them for sure.
Okay, here's another question, shifting gears a little bit. I'm not sure who asked this question, but I think this is actually a really important question that's being raised here. And it says, there seems to have been little emphasis on early treatment from our medical institutions in our country. Is this accurate? And what about early treatment? So in other words, the concern is everybody's obsessing about vaccines in the medical community, and they're not really paying adequate attention to early treatment once people do get COVID. What are your thoughts, both Paco and Mark?
What happens, for example, with the monoclonal antibodies, when we go over one of these waves, the demand is so high that it is very difficult to give the monoclonal antibodies to everyone who really needs them. So there's a lot of people that do not get them just because there's not enough supply.
So do you think that's a fundamental issue in the philosophical approach to treating COVID-19, or is that just simply an inability to manufacture the monoclonal antibodies that are needed?
It's an inability of not just just not getting them. It's complicated because, Mark, I mean, you're very fortunate that you have a lot of infusion centers throughout Florida to give the monoclonal antibodies, but really you need to give this in a clinic that is equipped to handle patients who have active COVID. You need to have special nurses to know how to infuse the product. Once you get the product, people have to stay in that office for about an hour, just monitoring for any side effects, and then they can leave. So it is a very time and people consuming process. So when you have a very high amount of people trying to get these, there's just not a lot of not a lot of places when you can get them easily. So that's why if we get the vaccine, we can prevent the backlog from all this on early treatment for COVID.
So in other words, what you're saying, Paco, and Mark, again, I want to make sure you get a chance to jump in here, is that that the emphasis on vaccination is actually appropriate emphasis, because it's better to keep people from getting the disease or having a severe disease than being concerned about treating it after the fact.
Yes.
So that the philosophical approach of the medical community, in your estimation, is the right one.
Yes. Yes. Right now, yeah, the issue is that if we run out of another example, when people end up in the hospital with severe COVID, there is one medication that we know works. It's something called tocilizumab, which is another very specific medication. We have had problems over the last 8 weeks or so because our supply of this medication is very spotty. Sometimes we have it, sometimes we don't. So if a patient comes in with COVID, we have to go to second tier or even third tier drugs to try to give them the benefit that this first tier medication could have given them. So yeah, the better we act on the prevention part, we'll be preventing a lot of problems in the down the line.
Mark, I'd like to give you a chance to weigh in here.
Well, I agree with Paco, and you're right. I am fortunate to live in a state that has infusion centers, but if everybody got the infusion that got infected, we'd be out of the antibodies very quickly. And another thing that kind of is shocking to me is that people go and they drive through these infusion centers and they may get an injection. That's what we're doing now. But those injections are over $1,000 an injection. And, I just think that's very significant. These things are not cheap either. They're very expensive, yet our state is practically giving them away. So I think we have to keep that in mind. We'll go bankrupt if everybody gets the infusion. The vaccine is much cheaper, and in my mind, it's the way to go. And it's why I personally was vaccinated.
Okay, here's another question. Can you comment on the distinctions between COVID cases, COVID infections, and hospitalizations due to COVID? On your views, should we not worry too much about the reports about cases versus reports about hospitalizations and death? Should we focus on the latter and not the former? And I think it's Alan, if I'm not mistaken, who's asked this question.
Well, it depends, because if you have a lot of cases and you have a non-vaccinated population, your number of hospitalizations and deaths is going to be pretty high. So that's really what it translates to.
So these measurements are actually not isolated from each other, but they actually are intertwined.
Correct.
Mark, any thoughts?
Yeah, I would agree with that. Yeah, I can't see much of a difference.
Let's see here. I'm going through the list of questions. Here's one from Bob. And again, this has to do with ivermectin and maybe even other treatments like hydroxychloroquine and things like that. Has the doctor-patient relationship been compromised to the point prescriptions like ivermectin that pharmacies can't fill and some MDs are apparently fired from their HMOs for early treatment? So, this is a little bit of a science and medicine question intertwined with probably some, more, more institutional type of concerns. But do you get what Bob is asking there?
You want to tackle that, Mark?
Well, nobody that I know has been fired, number one, for doing that. And I'm not sure I completely understood the question, but, I'm not using the ivermectin and the hydroxychloroquine because I don't know that they work. And if I had robust evidence that they did, I would be willing to use them, especially, in the face of not having other treatments. Fortunately, we do have treatments that we know work. And like I said, the monoclonal antibodies have been a real boon for us here and across the nation, that is. So that's what I'm standing on right now.
In another lifetime, I worked in research and development for a Fortune 500 company, and we actually developed a few pharmaceutical products as well as a number of the over-the-counter drugs. And this concept of safe and effective is really a very important concept that I think oftentimes isn't fully appreciated. Where the FDA demands that not only is a medicine safe, but it actually is effective, and it's just as dangerous to prescribe medications that are not effective as it is to prescribe medications that are unsafe. Paco, Mark, any comments on that statement of mine?
So I can tell you from our experience, when we started with the whole epidemic of COVID, we were looking everywhere to see what could help us, because the amount of people that were dying in the hospital was just staggering. So every time we saw a paper with some hope, I mean, we would actually be giving some of these medications, hydroxychloroquine mostly, in our hospital, because there were indications that this was working. Turns out that it really has no good effect at the end of all this. So right now that we have proven approaches like the monoclonal antibodies early on, to me, it really makes no sense to try something to see if it works, unless we were doing this in a very well-controlled clinical trial, which, that's a different story. But right now, if I had to say, well, do we compare ivermectin versus monoclonal antibodies? By far, we know the monoclonals work. So why should I waste my time giving the ivermectin? The patient-physician relationship has been damaged in a way, not in our setting, but we know areas very close to us where there have been even, some lawsuits that were people not to, for them to give the patients specific drugs. And to tell you the truth, the issue, for example, with the ivermectin, we do not have any data. I do not know how to use it. The studies that did it in vitro, you needed very high doses of the medication for it to even do what it's supposed to do. So I wouldn't even know how to prescribe ivermectin for COVID, because I don't know what dose is really effective. So I do not, as Mark says, would not give a patient something that may harm instead of making any good.
Are there known side effects? Oh yeah, please go ahead. Please go ahead.
I just wanted to add something, and that is, the history of medicine is littered with these stories over the past 150 to 200 years of society out of desperation looking for a treatment, especially in the heat of the battle. And it looks like something might work. And of course, it's employed. And then with time, they look back and they realize, no, it didn't work at all. And I can think of all sorts of outbreaks with cholera in London and, 100 years ago. And they were desperate. And I have never seen that level of desperation as I saw when COVID hit and all of a sudden hundreds of thousands of people started dying and we had no treatment. And I can understand how that we were grabbing at anything we could to see if it would work. And I think that ivermectin and hydroxychloroquine are examples of that. And time has gone on and we still have not had, and correct me if I'm wrong, Paco, any robust data. And a lot of people gave it a try, but we really didn't see convincing evidence with time that these things worked. But once again, I would say if they did, I would be prescribing them if I really thought that were the case. And nobody's holding a gun to my head, at least at this point in time, telling me what I can and can't do.
Okay, thank you, Mark. Stephen asks, and we're running out of time here, so we're down to just a little bit over 10 minutes left. Stephen asks, is there a possibility of adverse side effects from the vaccines that may not appear until years later?
There's a possibility, yeah, but because, right now, from all the people that have had the vaccines, we have a record of what are the side effects. If those happen, they might be very rare, unusual. That's probably what I would expect at this point. And of course, other things like you're talking about the infertility issue, we won't know until, there's a population-wide analysis on what happened with the vaccine, and that will take many years to tell.
But I mean, it seems to me that, and this is, the biochemist, speaking here, it seems to me though, that you could at least, if as you understand the mechanism of how the vaccine is operating, provide a reasonable conjecture as to whether or not you would anticipate long-term effects.
Correct.
So
we don't see anything.
Right, because for the messenger RNA vaccines, as Mark pointed out, that messenger RNA is a highly volatile, highly labile molecule that very readily will break down. And in fact, to develop the mRNA vaccines, people actually had to modify the RNA to ensure that it would actually have long enough survivability to get into the cells, and also to shield it from the immune system as well. But then that mRNA is going to break down quickly, even if the spike protein hangs around, inside the cell, or makes its way into the nucleus or something like that. Proteins have a finite lifetime, and they're going to break down. So the active agents are really very short-lived within the body, right? And so you wouldn't anticipate long-term effects for that reason.
Yeah.
But anyway,
I agree.
My thoughts. But okay, let's see. Let me see here. I'm quickly scanning the questions. Okay, here's one from George. As Christian physicians, how do you engage with patients that refuse the vaccine on religious grounds? For instance, because of the vaccines maybe having a past link to in their development to an elective abortion.
For that specific question, I would direct you to the white paper written amazingly by Dr. Fuz Rana and George Harassin that is in the RTB website. It is a very, very well written article that goes along all the ethics about the vaccines.
Well, that's kind of you to say, Paco. But if I get the question here, in a sense, I think maybe the question is, if somebody refuses the vaccine for philosophical or religious purposes, I mean, how do you react as a physician? You know, it seems that both of you would strongly encourage patients, again, you know, all things considered, to receive vaccines. But if somebody has a philosophical or religious objection, how do you respond to that? I mean, how do you respond to the fact that receiving medical care really is a personal decision on the part of the patient?
I would respond with respect for the decision and treating them as anybody else without any difference.
Same
Mark.
here, Fuzz. I've actually faced this quite a bit, and I agree with Paco. Look, these are our patients. These are human persons. I respect their decisions. You know, I do my best to give them good information. And I remind them that I'm not God and that I'm not all-knowing, but I have a certain amount of information and I try to pass that along, but I respect their decision.
Okay, let's see here. I think there's maybe one more question that we haven't addressed here. This one is from someone that named Smith. Why are we not aspirating vaccines to ensure they aren't delivered into arteries? We now have studies that show adeno and mRNA vaccines should not end up in the bloodstream or they can cause problems. Can you comment? So I'm not sure I've ever heard that concern. Paco, Mark, any thoughts on that?
Don't have much